So thank you for joining today. Sorry for the technical difficulties. We'll just give everyone maybe 1 more minute to log in because of the technical difficulties, and then go ahead and get started. Our moderator today will be Professor Sriram Dasu. Please introduce yourself whenever you're ready, Professor.
Yeah, so welcome everyone. It looks like we have all the speakers in the room. That's right. Yes, I think so. Yeah, so this is track 9, and it's health equity and reaching the last mile. And we have 3 presenters with 3 very interesting topics. The first topic has got to do with access to life-saving commodities in remote locations that are populated by nomadic communities. And this is from the In Supply Health Limited Group. And we have 2 speakers, Joyce Ovala and George Okello. So let's start. You have roughly 25 minutes. That includes questions. And so please go ahead.
Thank you, everyone, and welcome. I believe we had a recording. Could it be uploaded, please?
Yes, give me 1 second. I'm sorry.
Thank you.
Hello, everyone, and welcome. Thank you for your interest in our presentation, in which we'll share our experience in using Systock approach in making access to life-saving commodities a possibility for remote, hard-to-reach nomadic communities in Kenya's arid and semi-arid lands. I am Joyce Owola, a supply chain analyst working within Supply Health, and with me is George Okello, a senior supply chain analyst working within Supply Health, whom you'll hear from as he presents other sections of the presentation. And as a note, we would like you to know that we'll be using the acronym CHVs for Community Health Volunteer, CHF for Community Health Assistant, and ASAL quite a bit throughout the presentation. So we will start with the introduction. We will present on In Supply Health, who we are, the context, why we do what we do, the solutions we've been able to come up with, what the Systock approach is, the methods in designing the Systock application, and how to use Systock application. We'll also look at the challenges experienced while implementing Systock approach, the achievements that we have made when implementing Systock, and we'll have a conclusion after that. So, In Supply Health. In Supply Health is a health advisory firm affiliated to John Snow Inc. Research and Training Institute, and we provide customers guidance on supply chain management and design for the clients. We seek to transform lives by co-creating innovative and sustainable solutions for healthy communities. And we are based in East Africa with the offices in Tanzania and Kenya. We do envision collaboratively designing solutions for health challenges with the communities. We look at the SCALE project. So SCALE stands for Supply Chain Alternatives for Last Mile Equity. And through the support from Bill and Melinda Gates Foundation, SCALE is implemented in Samburu, Turkana, Wajir, and Mandera counties, as you see on the map. And the project is aimed at strengthening supply chain management at the community level and ensuring availability of commodities for the last mile. So most of the communities living in these regions are nomadic or semi-nomadic, and their lifestyle makes it challenging to access health services easily when they need it. And the neighboring regions are Sudan, Ethiopia, and Somalia, which have political instability, and thus the communities migrating to these areas cannot access the healthcare needs they require at an affordable cost. We look at some of the challenges facing the ASAL counties. The major challenge is because of unreliable absence of supply chain procedures and resupply processes of commodities. The CHVs are not able to get commodities. The second one is nomadic nature of the communities, which poses a challenge in resupplying CHVs, mostly causing stockouts, especially during the migrating seasons. In addition to nomadic communities challenges that we have mentioned, they have poor health-seeking behavior, they have low literacy levels, and the health facilities are vast and far apart because of the geography of the area. The human resources also allocated for the health facilities is inadequate to serve the communities. So what is the Systock approach? This is a supply chain strengthening approach, which enables CHVs to manage commodities. And it uses three components. The first being the mobile technology that provides logistics data. The second is user-friendly dashboard, which enhances end-to-end data visibility with standardized resupply processes. And the third is impact teams, which are used to strengthen data use, communication, and coordination in local problem solving of the supply chain. So Systock approach has demonstrated to work effectively with more than 300 CHVs in Siaya County. But to help achieve the universal health coverage goal and scale it up to the ASAL counties, Systock needed to work in all settings, including the remote hard-to-reach communities in the nomadic area. So the challenges mentioned earlier, and also poor infrastructure and poor network coverage, inadequate reporting tools, low capability to complete reports because of the low literacy, and lacking avenues to submit monthly reports are some of the reasons that lead to lack of availability of commodities for CHVs and quality data for decision making. So the diagram that you're seeing just briefly describes the process of reporting. The CHV reports data on the 28th of every month from the manual inventory card to the Systock app. And then the data is received on the app and resupply request is generated. So through the CHA portal, the reports are displayed and the CHA is able to know what to resupply to each CHV. And then they hold monthly impact teams at the end of each month to strengthen data use and solve challenges that the community health unit face. The method we used for designing Systock was the human-centered design, which is an approach to put the users of the app at the center of the system design, allowing us to modify the app to be user-friendly. And this enabled easy acceptance by the users, and the reporting for different indicators has improved since introduction and use of the app at the community level. So HCD was done in 3 steps. The first was insights, prototyping, and iteration, where we developed and evaluated 4 prototypes that led to the final design of Systock. The second was Systock system requirements and developments, where we documented decisions, requirements to revise Systock. And the last step was first rollout of impact teams, where we implemented impact teams at the county, sub-county levels to strengthen supply chain data use. We will look at the Android application for the CHVs, which is displayed on the screen. So the CHV is able to submit monthly reports. And these are the stock on hand, what has been dispensed during the month, and what has been received during that specific month. And then they're able to submit emergency reports This tab enables the CHVs to submit their stock on hand for each commodity, flagging out commodities which are below minimum months of stock, which will then submit an emergency order to the community health assistant, who is the CHV supervisor. And then when the CHV has been resupplied, they are also able to submit a receipt report for the emergency order that has been resupplied. We'll also look at the feature phone, USSD. So the CHV uses the inventory card daily to track the dispensed commodities. And at the end of the month, they do a physical count of all the usable commodities that are remaining. The stock on hand after the physical count, the total quantity that they have dispensed during the month, and the quantity that has been received is then submitted on Systock by the community health volunteer using their Systock account. And we'll also note that the community health assistant can delegate and report on behalf of the CHV who has no phone. And once they submit the report, they get a thank you note sent to them to enable them know that the report has been submitted successfully, as you can see. The CHA portal supports the CHVs. The CHA uses this to support the CHV, and what the CHA is able to do on validation, they're able to review quality of reports that the CHV submits. It has the user management, which enables the community health assistant to add CHVs or edit details for existing CHVs. And then we also have user-friendly dashboard that helps in monitoring the performance of the CHVs. And the CHA is able to delegate to support CHVs who cannot report or who have no phone. And lastly, CHA reporting receipts, which sends a communication message to the community health volunteer that the order that they had placed is ready to be picked. Thank you, and George will take you through the
Thank you, and welcome to the next session of the presentation. And as we had mentioned earlier, we talked about the human-centered design, and the next phase is an enhancement that has been done on Systock to ensure that the barriers for reporting have been reduced for the CHV. So how does Systock paper EMR works? Let's say the CHV in our presentation called Lolopool fills out the paper form. Lolopool takes a picture of the form using any phone and then sends the report, and the supervisor, Lolopool supervisor, receives her stock data and uses it to supply. So how does it work in detail? So the CHV logs into their user account using their username and password. And the first pop-up is on the picture that scans the part of the report. And then they have the capacity to review the data that they've captured. And once done, they can sync it to the cloud so that the report is seen in the system. And this app also works offline, and therefore syncing can be done when the CHV comes back online. So what are some of the key indicators that we've been looking at? One, for the Systock app include reporting rates, where we look at the percentage of CHVs who have submitted reports on their stock on hand, dispensed, and receipt for a particular month per county. The second indicator we look at is the resupply indicator, where we look at the reports on commodities received and emergency orders resupplied to the CHVs per month. The third indicator is average monthly consumption of the quantity consumed in the last 3 months, which helps in knowing the demand for each commodity. And lastly, the stock status, well, monitoring, where we're able to know the month of stock each commodity, and for the commodities with less than 1 month of stock, they are marked with a red alert to the decision makers that makes order for resupply easy. What are some of the learnings that we've had over the period? For child learning session, a meeting that is held quarterly in each county that brings together the community health assistants, pharmacists, and community strategy focal persons at the sub-county and county level with one objective of sharing knowledge to solve challenges faced and improve the community health unit's performance. Now let us look at the reportings that we've had over the last 1 year. Over the last 1 year, over 90% of CHVs have been submitting stock on hand and quantity dispensed every month for their community units. There has been significant improvement in submission of receipt reports in all the 4 counties. Due to frequent stockouts of essential commodities, the CHVs have had a challenge reporting 0 when they don't receive any commodities. The CHARs have to follow up on using the CHAR portal. Now, what are some of the significance we get from the reporting rate? The reports submitted by CHVs support forecasting and quantification, resupply, use of quality data in decision-making, efficient commodity management by CHVs, and flagging of stockouts at facility and community level. For the next slide, we're going to talk about the stock status as of September 2021. And the color codes are used to indicate stock levels of different commodities at community level and at the link facility. This enables the decision makers to decide on appropriate measures to take in each case, whether they are understocked, stocked between minimum and maximum, or they are overstocked. What are the order fill rates for each commodity? The order fill rates for each commodity to the CHVs enables the counties to know if the demand was met over time. What are some of the challenges we've experienced over time during our implementation of Systock? 1, there has been frequent stockouts of commodities in linked facilities that should resupply the CHVs. The Systock has had Systock app glitches, dropout of CHVs and CHARs who were trained on using the Systock app, low literacy levels of some CHVs, which eventually led to the CHAR submitting reports on their behalf. And lastly, late report submission by CHVs, prompting the CHARs to follow up on who's to report. Some of the achievements we've had is in designing the supply chain models to suit the cultural and geographical barriers in the nomadic communities. The linking of Systock data to the national system database makes data accessible to stakeholders for monitoring and decision-making of health supply chains. The health facilities have more confidence in resupplying commodities to the CHVs since they are guided by available data and calculations in Systock. Lastly, implementing partners like Save the Children have taken up Systock approach to manage and monitor supply of commodities they issue to the CHVs in different counties. Here are our conclusions. Systock approach has increased data visibility and data use in resupply process at the community level. This enables the county governments to factor in purchase and supply CHV kits to the CHVs in their counties through their linked facilities. And because of integration of Systock reporting to the GHIS database, the approach will be scaled up and used by CHVs in other counties in Kenya, enabling the country to achieve the primary healthcare goals where each citizen is able to take charge of improving their own health at the community level. Thank you, and we welcome questions and discussions.
Thank you very much, Joyce and George. It's a very, very inspiring and interesting presentation. We have a few minutes for questions, and I'll open up the floor for questions. Anyone have any questions, please? All right, let me ask, I'm really like the simplicity of the app and the wonderful, okay, there is a question from Leon. How does Systock integrate with the logistics, with the logistic provider system? Which countries is Systock implemented in?
Thank you so much, Siram, and thanks everyone for your attention. And I appreciate the questions that are coming in. We are a team, and I'm glad to be joined by our lead for MLE and part of the leadership that coined Systock from pilot to success in scale. Ken, can you say hi and probably answer the first question as we tackle the second and third with Joyce?
Thank you, George. So I think let me start with the easiest one. Where is Systock being implemented? It's in Kenya, and we are specifically implementing it in 5 counties at the subnational, the first subnational unit in the country. So we are what is presented is how it was being implemented in the 4 ASAL counties, that is the arid and semi-arid and arid lands. George?
Thank you, Ken. And just before that, of Systock into the Kenyan health systems, it was successfully implemented in Malawi. And the successes of implementation of Systock in Malawi enabled us to customize this approach to fit in our context in order to push the agenda for access to health commodities a reality. So I'll try and answer the second question. Does Systock integrate with logistic provider system? I would say yes and no. And yes, in that we've managed to integrate Systock into the Kenya National Health Information System, KHIS, that captures all levels of data for the health systems, service data, commodities data, consumption data, and therefore this is a platform where you can interact with this data and correlate how Systock plays an integral part in its interaction. And 2, and no, because Systock has not yet been improved to be a transactional system. And so the data that is collected on at the end of the month. And it is only specific to commodities data. And so we are unable to interact with other levels of data like services data at the level of use by the community health volunteers.
So we have one more question. It has to, from Ona. It has to do with how do you track the nomad supply to the nomadic population? I think it's another very interesting question. Yeah.
Maybe I can answer that. So for the nomadic communities in where we were working, so we partnered with another project called Nomadic Health Project, which specifically had got community health units for the nomadic community, meaning the community health workers in the context of the majority of people are able to move together with their members. So within the system, it has been put said that when you have to have a resupply in a different setting, because as you move, your link facility will obviously change. So it has been given that ability that you can choose the other resupply point. Alternatively, you are also able to create give like a double of the maximum quantities that are required. So if someone needed the average monthly consumption maybe is 100, so you'll double it to 200 so that it can last them for the time that they will be away until they come back. And this is particularly it was being piloted by the Nomadic Health Project, and we provided the technological solution to help them support that. Hence, they're able to plan for what quantities do they need to resupply to the community health volunteers, even as they move along with their communities.
Thank you very much for a very interesting and fascinating presentation. Fantastic work. It's really a pleasure listening to what you have done. So with that, I will move to the next presentation. It's strengthening integrated vaccine last mile delivery systems during during COVID. And we have Jennifer from the Clinton Health Access and Edward from the Kwale County who will tell us about how they strengthen the vaccine last mile delivery.
Thank you. Good morning, good afternoon, good evening to all. I'm going to present for the next few minutes to talk about the strengthening of integrated vaccine last mile delivery systems during the COVID-19 pandemic, and we'll share some of the results we managed to get from the pilot, but as well as the challenges and lessons learned. And we are going to focus on the Kwale County, which is located in Kenya. So I'm Jennifer Adungosi. I work with the vaccines team, the Kenyan chapter of the Clinton Health Access Initiative. And I'm going to do this presentation with Edward Mumbo, who is the immunization focal person based in Kwale County. So before we go to the next slide, so I wanted to give just a bit of introduction of the pilot. And this pilot was really born from the effective vaccines management assessment that had been done earlier in the country. And one of the key gaps that was identified was the stockouts levels across the country. And some of the engagement we had both at the national and the county, as well as down to the health facilities. One of the key gaps that was identified was stockouts, and mainly contributed by lack of transport or means of transport to collect and deliver the vaccines down to the health facilities. So that's how this last mile pilot was born. And we had discussions both with the donor, who is the Bill and Melinda Gates Foundation, but also the National Vaccines and Immunization Program, which we commonly refer to as NVIP. And we had a discussion with Kwale County as our first county to carry out this pilot. And that's how this pilot was born. Next. So CHAI as an organization, through the support of Bill and Melinda Gates Foundation, has been supporting several countries carry out the last mile distribution. And in Kenya, it has been supporting 3 major counties from the map that you can see. Uasin Gishu County is a county that represents the Rift Valley region. Kisii County represents the Nyanza Basin region. For today, we are going to focus on Kwale County. Kwale County is located at the coastal part of the country, and mainly at the south coast. It is a tourist county with a population of over 800,000 people as per the 2019 census. It's divided into 4 sub-counties, and each sub-county really represents a different disposition. We have, it stretches over to, flows over to a park. There's a sub-county that borders Tanzania, but also we have a sub-county that really has resources in terms of it being a tourist center for the county. The county has, by the time we are carrying out this pilot, it had over 120 immunizing sites. And one of the reasons we picked on this county also is that it offered more than one mode of transport. So it has both a road as a means of transport, but as well as water as such. So our main focus really was to tackle this big elephant in the room, which was stockouts of vaccines at the lowest level. And by the time we were starting this, prior to this pilot, we had more than 80% of the health facilities reporting at least stockouts of stocks of antigens being below minimum levels. But what really saddened us was the average stockout rate of more than 28 days at any given time, meaning that at any given time, we had over 30% of facilities reporting stockouts for more than a month. As such, as part of our pilot, we did follow up with 50 health facilities that we monitored across the pilot, early COVID, prior COVID, early COVID, and late COVID era, which we refer to baseline, midline, and endline data. Next. So this slide really is just to give us a snapshot of what really happens in terms of the immunization supply chain system in the country. So before, prior to the pilot, really what happens in the country is that as a country, we get vaccines and they're stored at a central vaccine store on a quarterly basis, all conditions held constant. And on a quarterly basis, through the UNICEF contracted third-party logistic partner, distribution is done to the next level, which is the regional vaccine store. And that is where, prior to the pilot, where the last mile ends. So from that point, the sub-county vaccine stores are made to plan on collection of their vaccines from the regional vaccine stores, and the health facilities are meant to plan and collect their vaccines from the vaccine store, sub-county vaccine store. What the pilot really came to do, what we were aiming at, is that we stretch down to the health facilities in terms of last mile. And so once the vaccines have been distributed to the regional vaccine stores, then our idea was that the county takes over and collects vaccines on behalf of their sub-counties. And once the vaccines are in the county goes ahead and distributes to the sub-county vaccine stores. And on a monthly basis, the sub-county teams go down and distribute these vaccines to the health facilities. Part of the discussion we had with Kwale County as we're proposing this pilot was a request from them that we do integration. And this came in handy. And we had the discussion way before even COVID, we heard of COVID. But it came in handy, especially during the COVID era, because now we were able to utilize the limited resources, leverage on the limited resources, and ensure at least we have commodities being supplied at one given point in time away from the vaccines. And the integration that we are requesting for, apart from vaccines being distributed to the last mile, can we have other commodities, health commodities distributed down to the health facilities? But also on top of that, can we have other cadres apart from the immunization focal people? And in this case, we had the health records officers who are very key in terms of data quality checks and ensuring that the right tools are in use. The pharmacists who are very key in terms of ensuring other commodities are distributed. And also we had on a rotational basis, other cadres, considering that the biomedical engineering are very key in terms of cold chain maintenance. And any other officer who we saw fit would fit during the distribution and depending on the needs of that facility at that point in time during the visit. Next. So this is just to show how we carried out the pilots, and the methodology we used was more observational assessment. And as I alluded earlier, we did carry out a cross-sectional data collection and use the survey CTO as a tool to collect that data. The 50 facilities that we followed through the pilot really were selected based on a few indicators. One was what type of facilities were they? So we mixed both the government, the private, and the faith-owned organizations just to see how stock levels differ across the different types. But also the performance, the immunization performance of these facilities was also key. The levels of the facility was one of the other areas that we thought would be key for us to select these facilities, considering, we did mix level 2, level 3, and level 4. And level 2 in this case is your dispensary, level 3 is your health centers, and level 4 is your sub-county referral hospitals, but also the geographical representation of the different facilities. And here we're looking at the distance from the facility to the sub-county stores and how that really affects availability and access of vaccines and other commodities. Next. So here for this graph, really, our take was to just show the impact of COVID on the immunization supply chain, more so during prior and during the implementation of the pilot. So during the launch, sometimes in September 2019, really, we had not been hit by COVID, the COVID pandemic, and we started off on a very good note. So we did launch it and we kicked off and everybody was on board, both at the county level and the sub-county as well as the facilities. When we did have our first case, reported one in China, as Africans were like, no, as we are good to go, as in we have strong immunity, this is a white people issue. But then when we had our first case come mid of March, that's when it hit us hard. So there was a bit of disruption in terms of our routine functionality, and also the pilot was really hit. And if you look at around June, April, May, June, that's the time when the country did put up some constraints or restrictions on movement. And this affected also the distribution and the pilot. Sometimes in August, we did kind of get a bit of a grip and we thought that we can handle this. But then come end of the year, the cases did rise. And that's the time we were talking about introduction of vaccines. So there was a disruption of this pilot because now all resources were, allocated or relocated to curbing this pandemic. Next. Next slide, please. Oh, on my end, I can't. Okay, so I can't see it on my screen. Sorry. The next slide. Okay, so thank you. So then, away from the story, so what was the impact of this pilot, and did we manage to achieve what we are looking for, or the expected outcomes in terms of reducing stockouts and increasing availability and access of vaccines at the lowest level? Across the periods, we did see a reduction in terms of stockout, overall stockout, health facilities reporting stockouts, and we did have a 20% reduction from 80% to 60%. We also did see a reduction in terms of the health facilities that were understocked, and this is what we refer to health facilities being below minimum stock levels, reduced from 88% to 50% as of end of the pilot. In terms of overstocking, and this is what we refer to commonly as hoarding, we did see a reduction from 79% to 69% as of the end of the pilot. And the impact of really just a bit of to make us understand the impact of understocking really leads to missed opportunities that really affect at the end of the day the uptake of vaccines and the coverage, the overall bit of, improving the access to vaccines and immunization space at large. But also overstocking is one area that as any manager, you wouldn't want to be there, because this fear of, expiries is what really we fear, but also as one person or one facility holds these vaccines and is overstocked, it causes a missed opportunity and lack of vaccines in another facility, leading to stockout. But also this can be attributed, and if you look at the green bar, both at health facilities, the stockouts, and health facilities that were overstocked, there was an increment. And this was during March, April, May, where now that's when the pilot had started kicking off, and we were doing so much in terms of carrying out on-job trainings and mentorship. But then that's also the time that we did have the closure of the country in terms of the restrictions given. So people had not really embraced the use of the forecasting sheets, the importance of carrying out quality ordering and ensuring that your data is accurate. But across the period of the the pilot, really, we did see that did take place, and we saw the impact of it as the pilot went by. Next. So as part of ensuring that we have access and availability of stocks at the lowest level, one of the indicators we're tracking was the number of days it took for one to place an order and get their order fulfillment. And our SI unit, or what we are targeting, was the increment in the number of facilities that did put up an order and receive their order fulfillment within 1 to 7 days. That we did see increase from 15% to 36%. By the end of the pilot, really, we did see that there was a reduction in the number of facilities that had stockouts of between 22 to 28 days, from 11% to 2%. What really we didn't achieve much is, the number of facilities that had stockouts more than 28 days. Yes, there was a reduction of 7% from 37 at baseline to 30%, but that really did not increase. And that can be, associated or affiliated to the pandemic by default, because there was a lot of redirection of resources in form of physical as well as the human resource, but also the stockouts that came from the national level. Remember, during this whole period when we got the pandemic hit the country, there was redirection or prioritization both from the national level down to the health facilities. We did have delay in terms of access to vaccines in the country, as well as distribution, because we are all trying to understand how to tackle the pandemic. But despite that, we did have completeness, a number of health facilities that had complete deliveries, and it improved from 48% to 71% by the end of the pilot. Timeliness was affected, and this can be attributed to the fact that the little resources that we had were overstretched in terms of the people who are responsible for carrying out the pilot, who are mainly our sub-county health management team members, were stretched, and some of them were really called upon to even go back to service delivery with the communication that we got. Healthcare workers worked for 2 weeks and then they had to go for quarantine for another 2 weeks. So some of the managers really had to go back to service delivery. That's how, that's one of the contribution to let, that affected timely delivery. But also the stock out at the national level cascading down also did contribute to delayed deliveries. Next. So as part of integration, as I had alluded to earlier, one of the key indicators we're looking at, apart from the vaccines being distributed down to the last mile, which are the health facilities, which other commodities were we able to distribute and integrate in this space? And as you can see from your graph on that should be your left, we did have commodities, also especially the essential medicine, the antiretroviral drugs, as well as the tuberculosis drugs and non-pharmaceuticals, being one of the key commodities that were distributed across the facilities as vaccines were distributed. If you look at the lab commodity, really, we didn't perform well as of the end of the pilot. And this can be attributed to the different supply chain system for these commodities. And number two, not all facilities that are immunizing really do offer lab, physical lab services. So most of them really, it's all about referring the lab services to another facility. So that's why you see the lab commodities really did not perform well as of the end of the pilot. On the other area, as part of why we had integrated teams, was to offer a wholesome supervision and mentorship to this facility at one given point in time. And if you look at the areas really that got to be supervised, we also see that tuberculosis took the day and maternal child health. And by default, maternal child health did perform well because vaccines really falls under the maternal child department. But also this goes ahead and shows that there was integration in terms of the cadres that we did involve during this distribution took up the mantle and did carry out the expected expected responsibility, or what was expected of them to carry to offer supervision at one given point in time. If you look at the laboratory in terms of programs supervised, it did do well, and this should not be attached to the commodities because these facilities still do offer some form of lab services. Most of them, if they don't have a physical infrastructure in terms of a laboratory, they do offer lab services in terms of rapid testing as well as referring. So also there was a bit of mentorship carried out in terms of that area. Next. And I know the money issue now comes in and plays a very big role in terms of, was this cost effective, and what is in for the country or this county. So before the pilot or prior to the pilot, and this is a routine thing that happens across the country in the health department, that it's expected that the county and the sub-county health management teams carry out a support supervision every quarter. So this supervision really is, I call it a checklist, sorry to say so, because it's time bound. It's 5 days in a quarter, and a quarter represents 3 months. So it's carried out once. And during this supervision, really, we just do a tick and just do a summary report so that we meet our target as county health management members. But and if you look at the amount really spent during this time, it comes to around $5,400 around there. But to the pilot, really, we did spend more, meaning we did spend around $1,764,000, but there was more touch. And remember, this was done on a monthly basis across all the immunizing sites. And at this point, I would invite my co-presenter, Edward Mumbo, to take over and talk more about the implementation part of this pilot. Thank you.
Thank you very much, everybody on board. Good evening and good morning, where applicable. As Jennifer said, the implementation was very informative. And as we are looking at the just last slide, that we spent a little bit more money in supervision and on-the-job training and mentorship, is because of the sense of the integration and the frequency that we went to the facilities on monthly basis, opposed to the quarterly visit as earlier done. And this really made us achieve a lot in terms of making sure that people understand the immunization space as when you go there as a team, the lab person goes there, the HIV person goes there, the pharmacist goes there, the lab goes along with the team as well as the biomed. Then this makes everybody responsible. Everybody learns the concept, learns the immunization program and what happens. And this therefore gives a sense of a very strong teamwork and great achievement in the process. So apart from the justice supervision, we had an opportunity of the non-EPI staff really learning about EPI and appreciating the immunization space in the county. And in this regard, therefore, we are trying to recommend that if we are to do such continuously and harvesting the result that we want to have a really broad involvement of more persons in the immunization space. Apart from the immunization staff, the management of the specific county is very critical, because the managers in the county play a role in determining whether transport will be available, whether the other resources that are required to make sure that the last mile is achieved are available. And in this regard, therefore, as a county, today, if you went there, you would hear the administrators also talk very positively about the support that is required for the immunization space, for the supplies to be there when they are required and in good quantities. And for sustainability of this program, from the lessons learned, then we found that it is very, very, very cost effective. And as a county, we embedded the cost of carrying on with the last mile into our annual work plan based on the program-based budget. And as we are speaking now, the county is funding the services, or rather the activities that were being funded during the pilot. And this has been received very well by the health workers in the health facilities, that now it has saved them time from moving from the facilities to the sub-counties to collect the vaccines at the expense of self-delivery. And therefore, this is really been taken very well and something that we needed to do. And again, when we look at the issues of the sub-programs, it is a very cost-effective, and again, we are appreciating the need to integrate with other programs so that the benefits can be more in the county. Next. The next slide. I'm not saying the next slide.
Is it the conclusion slide?
So the conclusion in this regard is that this is something that we need really to support. We need to carry it on from wherever we are, because as we have seen in the results, the pilot really informed us a lot about how we are supposed to do things in order to improve the performance in the EPEG program, given the fact that the short pilot period that we had a very nice picture of reduction of the stock outs and also delivery of the supplies on time in the service delivery points as required. And this contributed to an improvement in the vaccination coverage in our county during that period that we carried out the study. And this is something that we need to sustain so that then we can have every targeted individual in the mission space receive the service at a time that they require. So I will again welcome us to look at the key challenges that we faced during this period. There are some sub-counties that actually did not have transport because, again, of the issues of competing priorities. So there are some counties that did not have really transport, therefore affecting the delivery system of the supplies to where they are required. Again, one thing that we appreciated was some of the forecasting sheet that the healthcare workers were using were not very accurate. And this was because of the challenge of inadequate knowledge and inadequate skills on how to do the forecasting and quantification. And as we were doing this, therefore, we had a really good opportunity of on-the-job training of the healthcare workers on how to do proper forecasting and quantification of the EPI commodities. Integration of this service was a bit challenging because sometimes some of the sub-county health management team members were not very versed with the EPI program. Therefore, we would go with them and they would behave like passengers in the primary times, but eventually they came on board, and you could hear a lab officer articulate immunization issues like the nurse would really articulate. So some of those challenges were like that, and we circumvented this by the on-the-job training and also trying to integrate the little or the small transport that the sub-counties had. And we learned quite good lessons in this, that if we had very good reliable transport in the system, the success of the last mile will be greatly achieved across all the levels. Again, we also learned that capacity building through on-the-job training, mentorship, and even operational level training of the healthcare workers is very critical if we are to succeed in the last mile project. And accurate ordering and forecasting of the commodities really played a very key role in reducing the overstocking and the understocking, because at a given time, every healthcare worker knew when to order and how much to order based on the minimum stocks and the maximum stocks that each level was required to stock at a given point in time. And these lessons that we learned, therefore, we are trying to scale them up in all the other facilities that did not participate in the pilot study, so that as a county, all the immunizing facilities, the 124 plus, are able to adhere to the protocols, so that then we can all harvest the positive gains in the immunization space. Next. So I welcome Jennifer to finish.
So can I intervene, please? If this is your last slide, I would like to cut in. We're running out of time. So thank you so much, Jennifer and George, for this excellent Jennifer and Edward, for giving us this overview of a very important and complex problem, and you've done a lot of work on this. And I would, in the interest of time, we've, the previous session ran over and we're running very tight. So my sincere apologies. If you have any questions, could you please answer them in chat? Again, I apologize for that. And now I would like to invite Professor Joel Conde to speak about, routine and on-demand medical drone delivery to remote and hard-to-reach health facilities in DRC. So, Professor Conde, yes.
Thank you, moderator, for this opportunity to present the result of the midline evaluation of the routine and on-demand medical drone delivery to remote or to reach health facilities in the Democratic Republic of Congo. Utilization of drone for transport of medical product is gaining interest from both national and local stakeholders in many countries due to many geographic and infrastructure challenges in remote areas. This map shows that the experience gathered so far is mainly focused in sub-Saharan Africa. For example, Rwanda and Ghana have had drone delivery program on a larger scale, which we call phase 3. Drone program in DRC, Malawi, and Madagascar are in more targeted areas. These are phase 2. Mozambique conducted phase 1 and is moving to phase 2, while Malawi government is planning to go national with on-demand drone delivery for all hard-to-reach health areas. This will be a phase 3 program. These phase 1, 2, and 3 depict the evolution in setting up a drone program. They require different types of evaluation and performance indicators as outlined in the Drone Evidence Generation Toolkit, which web link is provided on this slide. The focus of this presentation will be on the phase 2 drone program evaluation in Equator Province in DRC. Equator Province, one of the 26 provinces of the DRC, is larger than many countries. It's, for example, 4 times larger than Rwanda and has many remote populations. Health workers experience difficulties and spend many hours to collect vaccines from centralized locations. Thus, stockouts are very frequent. The drone network covers 22,000 square kilometers and will be expanded to more than 37,000 square kilometers after December 2021. In 2020, the DRC Ministry of Health, Village Reach, and the Equator Province Health Authorities designed a drone delivery program to supply health products to very remote or hard-to-reach health facilities. In local workshop, the greatest needs identified for the drone program were: first, monthly delivery of vaccines; second, reverse transport of lab samples; and third, other health products in transport in emergencies as needed to mitigate stockouts. 20 different immunization programs, including 9 vaccines, are supplied monthly, and quantity are adjusted in real time based on consumption and stock data. Electric drone designed and operated by Systock can fly at speed of 90 to 115 kilometers per hour, covering a geographic distance of 125 kilometers on a single battery charge, and each carrying up to 3 kilograms of medical products. Systock Aero's operations are managed and run by local drone pilot and ground teams. One of the biggest challenges of operating the flight is that many of the remote health facilities do not have access to mobile or internet connectivity. To date, the drones have transported over 125,000 vaccine doses, along with many other immunization products, 900 kilograms or 4,000 liters in total. In October, November, the drone transported large quantities of the yellow fever vaccine for a mass immunization campaign organized by the DRC Ministry of Health. More than 64,000 people, mainly young children under 1 year and pregnant women, have benefited from these products. Between 2 to 6 sub-aero drones have conducted over 2,200 flights, resulting in 867 product deliveries and covering 94,000 kilometers in the air. The integration of the drone into the DRC health supply chain offers an opportunity to assess if a drone transport system could help improve the delivery of immunization products to very remote or cut-off areas, leading to more consistent availability and lower stock out of vaccine and supplies in health facilities. The ultimate goal is to improve routine immunization of young children and pregnant women and general health services. Data from in-depth evaluation of drone program lasting more than 6 months has been scarce to date. This ongoing process and outcome evaluation in DRC is one of the first of its kind globally and will help inform stakeholders of the results, limitations, and possibilities for scaling up this new technology to other health areas in Ecuador, to new provinces in DRC, and to very remote areas of the world. The phase 2 program in Ecuador has developed a theory change which was used by the evaluation team to identify indicators to measure during the process evaluation. This phase 2 evaluation focuses mainly on short-term and medium-term results. These are mainly supply chain indicators directly influenced by drone transport. However, vaccination indicators, which are indirectly influenced by improved vaccine availability, are also monitored. The long-term results, which cannot be evaluated during phase 2, are better prevention, diagnosis, treatment for many infectious diseases. The main evaluation questions are presented on this slide. And these are the questions we are looking to answer during this phase 2 evaluation. The focus is on whether the drone transport system performs as expected when it comes to immunization product deliveries to very remote areas. Other key questions surround how drones have contributed to the productivity and capacity of health workers and the satisfaction of local community, and whether the drone influence health-seeking behavior. The evaluation results will help the DRC to improve drone scale-up in remote areas. This midline performance evaluation is part of a pre- and post-test evaluation study with baseline data collected in health facilities over 6 months in 2020 before the flight were introduced, and midline data collected in June 2021, about 3 to 5 months after drone flights started at 12 of the remote health facilities. Another midline data collection is planned earlier in 2022 in 22 2 health facilities and an end-line in mid-2022 in 24 health facilities. During end-line, household surveys will also be conducted, as well as data collection in a sample of satellite facilities and immunization supply chain cost data. In June 2021, Village Reach, the Ecuador Provincial Health Department and evaluator from Kinshasa School of Public Health conducted the midline data collection, which showed good progress for the key performance indicators compared to baseline data collected in 2020. There were also supportive supervision and feedback sessions with community leaders at 12 remote locations. Targets of supply chain indicator were set with Ecuador Province Health Department. The main drone hub is located at Sekliwenji, 1 hour outside Mandaka. Flight lasts 15 minutes to 1 hour each way, and 27 facilities received immunization product by drone and sent back lab sample and data. The midline evaluation showed promising results and strong local support for drone from both health workers and community leaders. Vaccine availability at all 12 remote drone sites evaluated in June 2021 was 102% compared to 78% at baseline, exceeding targets. When counting all 20 immunization products delivered by drone, availability was 102% at midline versus 73% at baseline. Stock out for all routine vaccine had been reduced to 0% for the prior 2 months, except for the BCG vaccine. Health workers from 6 most remote health centers saved 2 days of travel time each month thanks to the drone deliveries. All 12 sites were receiving vaccine in less than 2 hours. The proportion of sample collected to diagnose infectious diseases that arrived in a timely manner at the laboratory in the capital of Ecuador province improved from 10% to 52%. These are samples transported by road and by drone. On the other hand, the team observed overstocks in some health facilities when conducting physical counts. Overall, overstock and understock have decreased, and the percentage of health facilities that were stocked according to plan has increased. The percentage of vaccination sessions that were conducted in the community increased from 89% to 94%, plausibly linked to improved vaccine availability. No significant difference in vaccination coverage data, although there was a slight decline in the dropout rate of pentavalent. We observe high satisfaction rates with the drone program among health workers and in discussions with community leaders. The supervision team found that some community had built floating landing areas at health facilities that tend to get flooded, while others had built fencing around the landing location to allow the drone to land safely. There were rumors spreading false information in the community, but in most cases, it was indicated that people realized the rumors proved unfounded. Health workers and community leaders offered helpful suggestions to further improve the program. Mainly, drone volume capacity should be improved. Many of these facilities are very remote, so even if the vaccine comes by drone, the health workers still have to go to the district to pick up other health products. There are challenges and response that the drone program has set in place. Despite challenges early in the year, due to international shipment delays of drones from Australia to DRC caused by the COVID pandemic, the drone project now has a full fleet of 6 drones in country and is thus able to finish planning the expansion. The drone team was able to use drone to conduct on-demand deliveries for several months at 2 health centers where the refrigerator used for vaccine storage had stopped working. At this facility, the drone delivered product on the vaccination day. Conclusion drawn from Midline evaluation are outlined here. Vaccine availability, stock out rate, and health facility stock according to plan improved. Significant time saving for health workers, percentage of lab sample that arrived in a timely manner at the provincial laboratory improved, high satisfaction for health worker and community leaders, percentage of vaccination session conducted improved, driven by mobile session in communities, on-demand deliveries for facility with non-functional refrigerator. Potential supply chain efficiencies deriving from integrated product and two-way deliveries, evaluation data collection happening every 6 months, and this will include additional health facilities, household surveys, costing and cost effectiveness data at end line. This talk cannot be close without acknowledging institution and donor who made the drone project possible and this evaluation study possible. These are principally donors, drone project implementers, Village Reach, Soup Aero, DRC Ministry of Health, Ecuador Province, and the evaluation team constituted of University of California at Los Angeles DRC office and the Kinshasa School of Public Health. Thank you for your attention.
Thank you very much, Professor, for your, it's really a fascinating topic, the use of drones, and it's really heartening to see that this technology that has challenges with respect to economics is actually proving to be so valuable, and we're seeing some very nice results coming out of it. Unfortunately, we have exactly 1 minute, so if you have any quick questions, please go ahead and ask.
I have a question, just one question. Thank you for the presentation. What is the volume of the vaccines that the drone can lift from a point to point?
You have to unmute yourself. You're muted, Professor. We can't hear you. Can you unmute yourself?
Yes, I was saying that the quantity of vaccine that a drone can lift from one point to another is in terms of kilos, it's 3 kilos, and it's 5.4 liters. It's like 5,400 cubic centimeters.